Well, hello, everyone. Great you could join us for this webinar. I am Charlie Revis, President of Dysphonia International, and a big welcome to all of you to our webinar today, which is titled Vocal Cord Dysfunction, a poorly named common laryngeal disorder. Just a couple of housekeeping items for you before we get going into introductions. The webinar is being recorded and we will make it available on our YouTube channel and our website, which is dysphonia.org. And I would encourage all of you to look at our website, dysphonia.org. Lots of good information there that can be of help to you. We encourage your questions. And I would also want to emphasize to you, please submit your questions in the Q&A box on your Zoom screen, not the chat function. That makes it easier for us to track and get to your questions. We will answer as many questions as time will permit during the webinar, but I want to ensure you that all the questions will be answered and will be made part of the webinar and available on our website. I am extremely pleased to introduce our guest speakers for this webinar, Dr. Stacey Halum and speech language pathologist Rebecca Risser. Dr. Halum earned her medical degree from the Medical College of Wisconsin and did her otolaryngology residency at the Medical College of Wisconsin. She completed her laryngology fellowship at Wake Forest in Winston-Salem, North Carolina. Dr. Halum started her laryngology practice at Indiana University School of Medicine and was the first fellowship-trained laryngologist to practice clinically in the state of Indiana. In 2013, she started the Voice Clinic of Indiana, VCI, practice that she dedicated solely to the treatment of voice, swallowing, and airway disorders. In 2021, VCI was transformed into the first official Indiana University Health Voice Center. Dr. Halum is Associate Professor of Otolaryngology, Head and Neck Surgery at Indiana University School of Medicine, and Research Professor of Speech, Language, and Hearing Sciences at Purdue University. Dr. Halum has always been active in translational research, and she is investigating the use of stem cell therapies for the treatment of laryngologic disorders. Her research has been funded by the National Institutes of Health for more than a decade. Dr. Halum is active in various professional organizations and especially very active with the European Laryngological Society and has participated and supports the team for their Winter Days of Laryngology conference. And Dr. Halum serves as a member of Dysphonia International's Medical Advisory Board. Rebecca Risser came to the field of speech pathology from undergraduate and graduate degrees in music focused on vocal performance. She studied under Dr. Moya Andrews at Indiana University for her master's work in speech pathology. Her work has included neurocognitive rehabilitation, cognitive linguistic rehabilitation, swallowing, and voice. In 2007, she established Performance Voice Solutions and developed it into the preeminent voice rehabilitation facility in central Indiana. In 2014, She joined Dr. Halum to become a founding member of the Voice Clinic of Indiana and established the rehabilitation department with both a clinical fellowship and a student externship programs for speech language pathologists. The transformation of VCI to Indiana Health Voice Center provides Rebecca with increased opportunities to continue her work with patients and grow the field of clinical voice pathology for the next generation. So, Dr. Halum.
All right. Well, thank you so much for that intro. It's certainly a pleasure to be here today. Is everyone able to see this okay?
Yes.
Awesome, thanks. So I'm a big fan of Dysphonia International, very excited that we're branching out into some other areas outside of spasmodic dysphonia. And this is one that is definitely very near and dear to my heart. I think in Indiana, we tend to just see a tremendous amount of vocal cord dysfunction. I wanted to just briefly talk about vocal cord dysfunction and things that might masquerade as vocal cord dysfunction, as well as how do we evaluate this? What's the best way to evaluate these patients? How do we medically manage them? And where does therapy come in? So that's kind of an overview of what I plan on talking about today. And I think the plan would be that if you have any questions, please feel free to put them in the chat. And then as soon as we are done, we will go through all the questions and hopefully make this as interactive as possible with this Zoom format here. So as the title says, vocal cord dysfunction is not my favorite name. I think it's really a disservice to the disorder. It's like saying cardiac dysfunction. You know, what is cardiac dysfunction? Is that arrhythmia? Is that mitral valve prolapse? You know, what is hand dysfunction? Is that osteoarthritis? Is that trigger finger? Vocal cord dysfunction, it doesn't make a lot of sense because the vocal folds and the larynx are a very complex organ. So you can't just say vocal cord dysfunction and really be describing something. And it's funny right now because, you know, as Rebecca and I transitioned to IU Health Voice Center, we're in a situation with, as many health centers are, where there's just been a lot of turnover of staff. And so we have ended up with kind of all new schedulers. And the schedulers tend to just put vocal cord dysfunction down for any diagnosis related to the larynx. So all of my new patients right now, essentially, about 90% of them anyway, they come in and it says new patient, vocal cord dysfunction. And then I'll walk in the room and they'll have vocal fold paralysis, or it will say new patient, you know, vocal cord dysfunction. I walk in and they have spasmodic dysphonia. So it's kind of funny to me because it is, you know, understandable. I mean, in essence, they're correct because all these patients who have dysphonia, they do have a form of vocal cord dysfunction. And so the name just doesn't really do justice to what we're talking about. And that's where I think there really is a lot of confusion. So when we talk about vocal cord dysfunction medically, what we're typically talking about is not spasmodic dysphonia, it's not vocal fold paralysis, it's not these things listed, but it really is more of an issue with the vocal cords closing when the air is trying to come into the body. So what we tend to see is we get patients who are referred from pulmonologists and allergists, and they've done this kind of pulmonary flow loop testing. And what this looks like, basically, when you're breathing in, this is showing the airflow going, or I'm sorry, when you're breathing out, exhalation, this is the airflow coming out of the body. And then breathing in, this is the area where the inhalation, the airflow coming into the body. So what the pulmonologist or the allergist will often see is patients breathing out fine here, but when they go to breathe in, we see this kind of blunting of that inspiratory loop. And sometimes you'll actually see some wavering here. And that shows that, you know, the vocal cords might be either adducting or paradoxically moving and interfering with the ability to get a good breath in. So when they talk about vocal cord dysfunction, what they're really talking about is an airflow issue and generally not a voice issue. But the name, of course, doesn't do justice to that. So, again, when the pulmonologist or the allergist sends these patients to us, typically they're asking us, are the patient's vocal folds actively closing or adducting during inhalation? Is that causing them airway obstruction? So when I send a letter back or call these doctors who are referring these patients to us, they just want to know, is it VCD or is it not VCD? If I say, oh, I saw paradoxical motion, that doesn't usually mean a lot to them. Because in their world, this is the terminology they use. So that's why, I don't think we're ever going to get away from the name VCD, but I do think it's important just to understand that it's not, it doesn't encapsulate all vocal cord dysfunction problems. It really is talking just about airway. So
Dr. Halum? Dr. Halum, could I ask one quick favor? It looks like there's a toolbar on top of your PowerPoint presentation. Could you just move that maybe to the bottom? I'm not sure why it doesn't disappear.
Okay, let's see. Is it up in this area here?
Yeah, exactly. It may be able to let you drag it down.
Yeah, let me. Oh, yeah, I'm sorry about that. That is weird. All right. If I leave, I might lose you though. Should I just?
I think maybe if we leave it down there, that might work because at least it's not. Oh, and it's something else. Okay, there we go.
Okay. Yeah, let me know if it's blocking anything. I can always.
It looks good now, Stacey.
Okay. So the two major areas of vocal cord dysfunction that we're talking about today are going to be paradoxical vocal fold motion, which is also known as ELO, so exercise-induced laryngeal obstruction, or laryngospasm, which is an inducible laryngeal obstruction, ILO. So these are fairly recent names, ELO and ILO. I do think they're much more accurate than just saying vocal cord dysfunction for the reasons we talked about. And I think, as we move forward as laryngologists, I think we're going to use these terms more and more. And I think that speech language pathologists are already using these terms quite a bit. But, again, we're probably always going to have to say VCD or talk about vocal cord dysfunction when we're talking to our allergists and pulmonologists, because that is what they're very much used to. The challenge, again, with this VCD evaluation using pulmonary flow loops is we do have some disorders that do that same thing, where they actually have adduction of the vocal cords during breathing, and it can look like VCD on pulmonary function testing. One of them is respiratory dystonia. So that is actually in the class of laryngeal dystonias, just like spasmodic dysphonia. But this affects patients when they're breathing. And the other is laryngopharyngeal palatomyoclonus. This is often after some type of stroke or some type of brainstem or brain injury, where they'll have this rhythmic contraction of their vocal cords when they're breathing. And so both of these can look like VCD. So I'm just going to briefly show you some examples of these kind of more rare things, and then we'll get into more of the typical VCD. So this is an example of a patient who was sent to me with what they thought was going to be vocal cord dysfunction. Again, some pulmonary testing suggested that there was some extrathoracic variable airway obstruction. And you can see on his exam, right away, you start to see some contraction of the muscles, contraction of the pharyngeal muscles, contraction of the base of tongue here. As he's inhaling, you see this kind of contraction of the constrictor muscles going toward the base of tongue, as well as the laryngeal muscles adducting. And as we get a little bit closer here, you can see it's almost a circular pattern where the arytenoids, which are right here, are actually going anterior, contracting against that petiole of the epiglottis. So you're losing your laryngeal airway dramatically there as these muscle spasms are happening. But when he goes to voice, here we have a pretty normal video stroboscopy. He's able to voice, he's able to speak. And so this is an interesting case because again, it's a respiratory dystonia, which means it's specific to breathing. So the dystonias are very interesting in that they're task specific. So people who have spasmodic dysphonia, they have difficulty talking, but when they go to breathe, they can get a good breath. Patients with respiratory dystonia, when they go to breathe, they have all of these spasms. And so he ended up going through therapy over and over, and ultimately was not able to improve at all with therapy, because every time he thought about trying to get a big breath, every time he did sniffing, every time he did the typical things that we do in therapy, he ended up getting a little bit worse and feeling that tightness. And so he was a patient we ended up doing Botox on, and we Botoxed all the way from the nasopharynx down to the larynx, and also had him see neurology, and they started him on some medications too. And this is after his Botox. You can see his airways dramatically improved. His voice was a little bit weak, but he was very, very pleased with the improvement. And so this is something that can be mistaken for more of our classic vocal cord dysfunction, but it is really a neurologic disorder. So next one also can be kind of a red herring, in that this is a patient who was also sent with a diagnosis of possible vocal cord dysfunction. And here we see she's also got this kind of rhythmic contraction of her vocal cords down here, as well as the pharynx. But in her case, when she goes to voice, you can hear that shaky voice and that e. So this rhythmic spasming that she's having, it really never stops. It's there when she breathes, it's there when she voices.
8, 9.
And it does interfere with her breathing and her voicing. But this is called myoclonus. So this is the patient who had had a brain tumor removed, and afterwards has this rhythmic contraction of those muscles. It's not task specific. It's actually there all of the time. It can actually be very annoying to patients because they feel this contraction going on in their throat. It can be difficult to sleep. Sometimes they can hear clicking in their throat and in the ears. And so again, sometimes Botox can be helpful for these patients because it's not going to respond well to therapy. So when I think about vocal cord dysfunction, I think about the laryngeal adductor reflex. So the vocal folds are supposed to contract, so they're supposed to close to protect our airway when they sense any kind of chemical or mechanical threat. The vocal folds are really amazing if you think about it, that they have these incredible reflexes to protect us. The signals they get really come from two areas. One is the supralaryngeal nerve, which innervates the pharynx up here. And so if the supralaryngeal nerve senses any chemical irritation or mechanical irritation and thinks that perhaps the body is going to aspirate this and it's going to go down and do damage to the airway, it will send a signal to this nodose ganglion, which then sends in a brainstem loop a signal back to the recurrent laryngeal nerves to cause the vocal cords to go into full-blown adduction or closure. The other area where we often get signals is the esophagus. So there have been some really nice studies that have shown both chemical and mechanical stretching of the esophagus can again send this sensory signal back to the nodose ganglion and tell those vocal cords to go into an adduction or a closure state. So it's a protective reflex because, as the body senses something coming up the esophagus, it doesn't want that acid or that regurgitation to end up getting aspirated and going into our airways. And so in order to protect us, we have this laryngeal adductor reflex, and it tells those vocal cords to close, and it keeps us from aspirating, it keeps us safe. So it's a really important reflex. But the problem is this reflex can really go haywire. And that's what I tell our patients, this is a great reflex. It's actually very, very important, but it can go haywire and we feel like we've lost control of our breathing. And so with therapy, the main idea is that we want to use the patient's volitional control to regain abduction of the vocal folds on demand, essentially. So the patient's going to train with the therapist so they learn that they control those vocal cords. They know they can break a spell when they go into spasm. They know they can open up those vocal folds again. And once they get that control, it really helps with the anxiety piece. It really helps with just general overall improvement because they know what's going on in the throat and they know that they can overcome it, that the body is not taking on a mind of its own, and that they can actually overcome any of these reflexes volitionally. So what are the triggers? Again, as we mentioned, from those nerves, the esophagus is a big one. And this is research going way back. Dr. Sasaki and Shakir, they did some beautiful studies where they showed they could just distend the esophagus a little bit, and that was enough to trigger the laryngeal adductor reflex and those vocal cords to go into spasm. So we know that one is very important. We also know that chemical irritation is a big one. A lot of our patients have been exposed to chemicals at work. They might be exposed to cleaning agents. They might be exposed to excessive allergens. And that can really trigger some bad spells. And then many of our patients also have some type of superior laryngeal nerve dysfunction. So a lot of times we'll have patients who come in, they say, I had a really bad upper respiratory tract infection, a month earlier. And then after that, boy, everything is bothering my throat. Often I feel like my throat's going to close off without any warning. Sometimes, they have chronic cough with it, but they have this whole new heightened level of sensitivity. And so those are the patients where we start thinking, well, superior laryngeal nerve dysfunction might be involved here. So, as I mentioned, the two real common areas of VCD are ELO and ILO. So ELO is exercise-induced laryngeal obstruction. And this may be in two forms. One is more of the paradoxical vocal fold motion, where the vocal cords are paradoxically kind of closing when they should be opening, and this occurs during exercise. The other is where the patient's just in kind of a state of partial adduction of the vocal folds as they're exercising. So they're just not getting that really wide open abduction or the wide open airway that we want them to have. So both of these are things we're looking for when we're evaluating these patients. The other thing, though, to keep it in mind is it's not just the vocal folds. And that's why, I definitely like ELO as a term much, much better than vocal cord dysfunction, because I think it's a lot more accurate to what we're talking about. But it isn't just the larynx that we're worried about. In our athletes especially, we're looking at their head positioning. Is their head bobbing? Are they flexing? We want them really in more of a sniffing position where this whole airway is nice and open. We also want to make sure there's no other areas of obstruction. A lot of times it's the oropharynx. They will pull their tongue back. Their tongue can be obstructive. So it's not just the larynx, but the larynx tends to be one area that is tight when they're having these other positions, or other issues. So when we examine these patients, it's important that we examine them after whatever is triggering their problem. So with ELO, it's exercise. These are patients who often come in and say, they start to exercise and they feel that their throat, their chest gets really tight. They just can't get enough air in. They know they could perform better if they could just breathe. So these are patients where we'll have them either get on a treadmill or do a stationary bike, or we might have them just climb stairs or run outside. But we want to induce some of that shortness of breath that they're experiencing, so we can do a flexible laryngoscopy examination when they're actually short of breath and when they're actually feeling those symptoms and see what's going on. In ILO, it's a little different. So ILO, again, this is inducible laryngeal obstruction. So often their triggers are going to be a little different. They might be triggered by perfumes. They might be triggered by chemical cleaning agents, odors. Sometimes foods are a trigger. It's interesting because we've had some patients sent for dysphagia or swallowing problems. And they say, you know, it's always dry bread, you know, dry bread, crackers, things like that that trigger. And they're thinking that they're aspirating, but when we actually look, it's just that dry food getting to the back of the tongue and back of the throat, and it's triggering them to go into a laryngospasm. And their swallowing is actually fine. So those are patients, you know, we'll actually do more of a VCD kind of protocol, getting them improving the laryngospasm rather than doing dysphagia therapy. And then sometimes cold temperature can play a role. We certainly have patients where they're in their car and the air conditioning in the car triggers them to go into a full-blown laryngospasm, sometimes coughing with that. So it's important just to find out what the triggers might be for a given patient. With exercise-induced laryngeal obstruction, or ELO, we often see kind of a stereotype here, where these are our young, healthy patients. These are athletes who typically are overachievers. They're often straight-A students if they're in high school or college. They often come into the clinic accompanied by parents or their athletic trainers or coaches, and they note that the breathing really limits their performance. They've often tried inhalers. They've thought it's asthma, and that doesn't necessarily help. Sometimes even their parents or family members will notice that they can hear a stridor when the athlete is exercising. And they can feel, again, this tightness either in the throat or the chest. So this is an example of a patient with ELO. And he is actually a track athlete. He was about 17 at the time. And he was really, you know, talented, high-level athlete, was going to go to college on his, and do track in college. But you can I hear and see that he's got this soft stridor on inspiration. And there's just this kind of rocking of those vocal cords towards one another when he's trying to breathe in. And so Rebecca's actually working with him here. And as part of the therapy, we'll often include flexible laryngoscopy so we can give this kind of biofeedback to them. So, you know, she's had him running, she's gotten him winded, she brings him in, she looks, we can see that paradoxical motion going on, and then she works with him while the scope is still in place to really get that nice wide open larynx. So my part, as far as managing ELO, is really looking at what can we do to medically manage these patients. So one thing I think is very important, again, considering that physiology, that the esophageal distension can be a big trigger for these patients, is I like to put them on something like Gaviscon Advance or Reflux Gourmet. And I often will have our performers and our athletes do this about 15 minutes before they exercise. The idea is that these both have alginate in them. And so when they swallow it, it creates a nice coating at the top of the stomach, and it just prevents acid or any stomach contents from regurgitating. And then they don't get that esophageal distension, and then hopefully are much less likely to have that laryngeal adductor tone going on. The other thing is postnasal drainage, especially in Indiana here. We tend to see a lot of patients with postnasal drainage, lots of mucus. And so we'll have them get something like Simply Saline and just keep that with them, and then use that about 15 minutes before they exercise, just so they're not having any drainage going down into the larynx and triggering that laryngeal adductor reflex. And then if they are having problems with kind of a hypersensitive larynx or anxiety, sometimes just a low dose of amitriptyline, which is for sensory neuropathy, it can be really helpful in resetting their sensory threshold and getting them back to more of a normal state of sensitivity, so they can control their larynx a little bit better. So this is a example of a patient who came in with ELO, and we'd actually worked with her quite a bit with therapy, but she wasn't getting the improvement that we had hoped. She still felt like there was a lot going on here. And what you'll see, and she felt like every time she took a breath in, there was still some form of resistance. And what we're seeing is this cuneiform cartilage or cuneiform tubercle here, it's prolapsing every time she takes a breath in. So she's getting this kind of hooding effect. And when we breathe, most of our airflow needs to go through this area. So in her case, she just wasn't feeling this nice wide open airway, even doing the breathing exercises. And she really didn't have stridor, but she just had this element of obstruction and kind of prolapse of tissue that was impacting her airway. So this was kind of an unusual case in that we treated her surgically. We actually went in and we removed that prolapsing tissue, something we call supraglottoplasty. But we removed that cuneiform tubercle and released the tissue over here. And now you can see she really has a nice wide open airway. And back up a little bit. And no issues with prolapse. I actually didn't have her running at this point because she said she felt 100% better. She could feel right away that she wasn't having any more of that prolapsing tissue. So again, that's just showing that ELO can have some variable presentations too, but most patients do very, very well with open throat breathing therapy. Move this down here. So what about ILO? Well, ILO is definitely a little bit different. These patients may have quite a variety in their history. They can have very different clinical presentations, very different comorbidities. So there really isn't that stereotype like we might get with ELO. But what we do see with our ILO patients is they typically have more consistent symptoms. They'll come in and they'll say, oh my goodness, out of the blue, I just felt like my throat closed off. I just couldn't get air in or out. I thought I was going to die. Some of them will wake up in the middle of the night. They won't be able to breathe, feel like their throat is closed off. Sometimes they'll call 911. Sometimes they'll go to the emergency room. And then by the time they get to the emergency room, of course, that laryngeal adductor reflex has gone away. And suddenly they can catch their breath again. And they'll say, oh, the ER doctor thought I was crazy, because, they're fine by the time they get to the emergency room. So a lot of education comes in here. We want to figure out, what is actually inducing the ELO events for these patients. And then, of course, how do we control these triggers? So in some patients, it's going to be triggers like perfumes, odors, temperature changes, food textures. And some patients, they have no idea what's going on. They really have no warning. These are cases where I tend to think it's more of a reflux issue because, again, we have these kind of silent things that can be going on at the esophageal level. And the patient typically doesn't feel any GERD, doesn't feel any regurgitation, but they can trigger some pretty severe laryngeal adductor reflexes. And then the last thing is more of a chronic laryngospasm state. This is certainly more rare, but we have seen this in numerous cases where the patient just never feels like they can get a big breath. They feel like they constantly have some resistance. And we'll look in there and see that indeed they really are not abducting, they're not opening those vocal cords. And it's definitely exacerbated by stress. So these are cases where we, again, will often work on more anxiety management, trying to figure out what we can do to get the patient more relaxed. So this is an example of a patient. He's a 50-year-old gentleman who had been exposed to a chemical at work.
Much better. Okay.
And he basically breathed in, had a deep breath of a chemical that really irritated his throat. He went into full-blown laryngeal spasm, coughing, vomiting. and went home for the day and then tried to go back to work the next day, and just walking in and smelling the chemicals in the office, he could not work. And so he came in, he hadn't worked for about 3 weeks at the time that we saw him. And we just went to do a flexible laryngoscopy exam with video stroboscopy. And in doing the exam, he coughed and went into spasm to the point of vomiting. We actually had to try 3 different times. We ended up doing a lidocaine nebulizer, as well as about 3 times the normal dose of topical nasal anesthesia, just to get to the point that we could actually examine him. So it shows you just how these chemical exposures can make people super sensitive. So here's his exam, and he is able to voice, of course, but he does have a lot of muscle tension dysphonia, a lot of guarding. His larynx is just very guarded, very tight.
Oh. Yeah, it's all right. You're gonna
and he is just in this protective mode where he just really doesn't want to open up those vocal cords and get that full abduction. And this is after a lot of topical anesthesia. So this was a patient where obviously we want to start therapy right away, and this was extremely important for him. He could sniff some, so that was actually a good sign for therapy. He could get some abduction. But in addition to this, we want to reset his whole laryngeal threshold for spasm. So these are patients where I am very aggressive medically. I'll put them on like twice daily proton pump inhibitors, do that at least 3 months. We'll also have them do either Gaviscon Advance or Reflux Gourmet, which is an alginate. And again, that coats the stomach. It kind of keeps the regurgitation from happening. We'll work with their diet to really go to a bland, kind of low-fat, healthy diet. Avoid sleeping flat, try to elevate their head of bed. And then when they are doing better, we'll do some kind of testing like impedance or do a Bravo with a res tech, so we can get a little better idea what's going on from a reflux standpoint. But when he's, in this state where he can't even work, he can't do anything without going into spasms, our initial plan is just cool these patients off, just cool it off, get them to the point that they can work again. So in him, we also did, I think, some budesonide irrigations. We also managed some of the allergy piece that was going on. If we see they have a lot of clear watery drainage, we might do ipratropium. And then we want to, again, get that sensitivity piece down. So I'll do amitriptyline or Lyrica or gabapentin. Some of these medications that make the larynx less sensitive can be really helpful for these patients. Often I'll do amitriptyline in combination with gabapentin, and that works very well. You can kind of escalate both of them up until we reach a point that they're not having the spasms. Superior laryngeal nerve blocks are another option. I actually did in this example patient I ended up doing superior laryngeal nerve blocks, put steroid and Marcaine in bilaterally, and he responded really well to that. Had about a 50% reduction in his symptoms just after the first injection. So we did a series of 3 of these, and within about 6 months, he was able to go back to work. And then in extreme cases, we may even do topical medications like lidocaine nebulizer, where we have the patient breathe the nebulizer when they start to feel like their throat's going into a spasm, or in cases where they're chronically in spasm, we'll have them use that nebulizer at home. And we can also have them do gargles like Mary's Magic or Miles Solution, or we can have them use things like Tessalon pearls, all with the aim of just making their throat less sensitive. So with these hyperactive laryngeal adductor reflexes, we also have to control the environment. A lot of these are work exposures. So unfortunately, sometimes people have to take a break from work. When we do send them back to work, sometimes we'll have them use a PAPR or some type of very protective mask. And gradually we work them back to being able to resume normal activities. So the next example is a little more rare, but we have seen this in numerous patients where they come in and they just feel like they never get a good breath. And it can escalate. Stress certainly makes this much, much worse. This is one of the most severe cases that I've had, so I wanted to share it. This is a patient, she was in her early 20s. working. She had a lot of anxiety, a lot of stress, but felt like she could just never get a good breath.
2, 3, 4, 5, 6, 7, 8.
So you can see she's really not opening her vocal cords at all between counting, between words. And even our normal breathing therapy here, trying to get her to breathe through her nose, breathe through straw. She just really is not abducting. And so she is just walking around with this horrible stridor, you know, every step of the way she had stridor, and it had started as mild and just progressed until she cycled to this point that she had continuous stridor. And so I had Rebecca come in because at first I thought, well, maybe her vocal cords are paralyzed. I really could not get her to open up those vocal cords. So this is the same day. Rebecca's actually working with her here.
Okay, while we're in here, I'm going to be feeling your throat, okay? Just going to feel your throat. Oh, you know what? That's interesting. We're going to put your chin down slightly. Put the chin down there, right? Keep the chin down there. And go ease.
And she's just locked up. So even with the therapy, she can get a little more abduction. So at this point, we realized she definitely is not paralyzed. She can abduct, but she's just really got a severe case of laryngospasm. So this is not something we typically do as a first line, but in her case, because it was so severe and her improvement with therapy alone was so limited, we did do Botox injections. I ended up injecting 3.75 units into each of the adductor complexes. So with this, we did weaken the vocal cords. So her voice was weaker and swallowing. She had a little difficulty with swallowing liquids. But this is when she came back a couple of weeks later, and you can see her breathing is much better. So she's able to actually open those vocal cords, abduct those vocal cords. Oops, I choked a little bit there.
Big swallow here. Big swallow. Yeah. Okay, don't, yeah, okay.
And so she's able to get, oh no, sorry.
Mind over matter, chin out. And at this time, as you're doing this, I want you to sniff and do the open throat breathing exercise from.
So in her case, the combination of doing a little bit of Botox and then the therapy was really helpful. And then she was able to work with Rebecca, continuing on the therapy route, and learn those techniques. And then, you know, repeat Botox wasn't necessary. So it was really more of a jump start just to get her breathing better and give her a safe airway. And I have had patients where it's so extreme that
Good, and again. Now this time I want you to actually put your hand under your chair or something and pull up when you're doing it. Do you know what I'm talking about? Yeah, like that, and you're going to pull up really hard. He. Good, do it again. And see if you can go.
So you can see see in here, she's still very breathy. This is about a month out from the Botox. In her case, she wasn't on any medications that were inducing this. This was just purely a vocal cord dysfunction that had just worsened and worsened. So, you know, Botox was an option for her. I have had patients where they've been on medications that they can't get off of, especially the psych medications, unfortunately, bipolar medicines, and some of the medicines for depression, anxiety can sometimes trigger a form of chronic laryngospasm. And I did have one patient where we ended up actually having to trach the patient because we couldn't even get her to relax well enough with Botox to give her a safe airway. But it just shows you there's many tools in the toolbox for dealing with these vocal cord dysfunction patients, or what I should call them are ELO or ILO patients. And it's important that we get a good evaluation of these patients. And that means doing a laryngoscopy after the patient has been triggered. So whatever their specific trigger is. It's also important that we medically manage anything that might be contributing to their laryngeal spasms. And again, going back to that pathway that the nerves from the esophagus, the nerves from the supraglottic larynx, supralaryngeal nerve territory here, those all can trigger spasms. So we want to really try to calm down those areas and minimize the risk of spasms. And then therapy is definitely first line. Botox can be used in extreme cases, but therapy is absolutely number one. And with that, I'm going to turn it over to our speech language pathologist, Rebecca Risser.
Hello. I will start sharing my screen. Here we go. I'm going to go ahead and run through a couple of these things simply because Dr. Halum has already covered some of this information. But before I do, I said I just want to let you know that I'm really happy to be with you guys tonight. It's really fun to see everyone chiming in on the chat. You're from literally all over the world, and that is so cool. I also know this is a mixed group of people coming in, so I'm a shout out to my speech pathology peeps here. And then also, I know there are a lot of people that have had experience with spasmodic dysphonia and other voice disorders. So I know there may be some questions that you may have. We are very happy to do whatever we can to answer those questions for you. So here we go. So VCD and speech pathology have gone together. They're kind of like peanut butter and jelly in my world. I can't think of a time where I was not treating this. I would say this is about 40% of my caseload. And there's good cause. As behavioralists, as people who can change behavior or can induce behavior change in other people, we have a very strong basis in the physiology and the anatomy of head and neck for this. Modifications that happen as a result of the chronic cough or a result of, say, somebody has an infection of some sort, bronchial infection, the changes that can happen as a result of someone's response to it. So this chronic cough or difficulty breathing, or in many cases, it's been COVID more recently, where we have seen that the changes resulting from these events have manifested long past the resolution of that. So in other words, someone might get over bronchitis, someone is over COVID. We're seeing manifestations of vocal cord dysfunction and chronic cough well past that. We've talked about inducible laryngeal obstruction, so I won't go into it here. Our role in these different manifestations of it, though. So for ILO and ELO, they both will be manifesting very similarly, but again, triggered either by odors, temperatures, reflux, versus ELO, which is triggered by exercise. Panic attacks are also in this, and I'll just touch briefly on this. The literature would suggest that we really don't have a big role to play with this particular type of thing, but I would say, in fact, we do. I don't know too many people who have a hard time breathing that don't panic. So I think if it's not a primary diagnostic, it will certainly be a secondary diagnostic with this. And being able to control your upper airway, being able to control your breathing when it's in a condition like this goes a long way for handling both secondary panic, but also for those primary panic patients too. As a speech pathologist, we can help with some of these other diagnostics by way of helping to identify, but we are not primarily used as a frontline for some of these diagnostics. This is how our cases typically present, though. I'll have ELO, we'll have ILO in the same patient, along with asthma, along with panic, along with a few other things thrown in. So we're parsing and we're working through this very gently with these very special patients. So we do have a lot of comorbidities as we've gone through. Along with reflux, there's also eosinophilic esophagitis that can come through. And so we're working with our GI comrades there, along with celiac disease. Of course, laryngeal sensory neuropathy is a big one at the top of the list.
Our role in this then is, first of all, we start up here, you'll see a thorough case history. We'll start with that. Down here with intervention then, we're going to first of all see what we can do to help improve their laryngeal environment. Dr. Halum's role is the medical side of it, but sometimes we want to make sure that they're also taking care of their habits. In other words, what are they used to doing? Are they using menthol cough drops or really cold foods or liquids, which can trigger a cold sensitivity? Are they drinking enough water? Different things like that. Then we start by figuring out what do they feel right before they go into this episode. Many times they don't know. They just automatically, they find that this cough just begins or their breathing problem just begins. When we're able to back up a little bit, we're able to start finding that, in fact, they feel a tickle or they feel a little bit of pressure. Today, I had a patient that said she has this great big gurgling sensation that comes all the way up her chest, right into her throat, and she has to start coughing. Well, I would normally have said that sounds a lot like reflux, but she's just had surgery for reflux. So we're hoping to minimize that in some other ways. Then we start working with either open throat breathing or with ILOBI, which is, of course, the biphasic inhalation that goes with exercise-induced laryngeal obstruction. After we go through all of this, then we start desensitizing them to both their athletic and environmental triggers. So as far as respiratory retraining, this actually has a long history. Back to 1986 with Dr. Blager, who discovered open throat breathing and also called it wide open breathing, focusing on diaphragmatic breathing along with a relaxed throat. And a posterior oral pharyngeal stretch, because those are the same muscles that collapse or contract during a cough or vocal cord dysfunction. And if we can voluntarily stretch those open, then we've gained control again over our breathing in many cases. Todd Olin came onto the scene a little bit more recently in 2017. I believe that was when he initially published, maybe just before that. But he talks about ILOBI, this exercise-induced laryngeal obstruction biphasic inhalation. And there are 3 variants to it. I typically use the lip variant, or sorry, the tooth variant, but I know that other of my colleagues are using the lip or the tongue more frequently. In either of these cases, our whole point is to cause basically a disruption, an intentional disruption into this neural pattern. If we can do that, then we can, the brain starts learning something new very quickly, and pretty soon the old behaviors are no longer the go-to behaviors. The new behaviors start becoming more prominent. These are the instructions that I usually give for open throat breathing. In the interest of time, I probably won't go over those today, but know that this is something that is not difficult to do. And we're able to usually get mastery of this within 1 or 2 therapy sessions. ILOBI is a little bit different. This takes a little bit longer to gain mastery over it. These 7 tenets are usually applied. And once they are able to get mastery over it, they're able to use this the entire ride, the entire run, very effectively. This is an example of irritant-induced ILO. And I'm working with the patient. Her husband is my little assistant here, but this is a person who complained of difficulty breathing. She was in her 30s, difficulty breathing around certain. It's a normal exam, or maybe you can't see, but that's a normal exam.
Okay, and I'm going to coach you now.
Got a nice open airway.
I don't want you to do it yet, but
practicing open throat breathing first.
So this is where you're going to sniff.
So this is what that open throat breathing does. It forces that system open, just like that.
Not quite that. Yeah, that's actually pretty good though. Do that again. Yeah, but you're going to breathe in slow. So you're going to breathe in like over, we're going to try it first over a 2 count, and then we're going to extend it to a 4 count. Okay. So it's going to go like this. Like that. Try that.
That is a beautiful breath, let me tell you.
Yeah, do it again. Very good. Okay, so this is where I'm going to have you bring the lotion over.
This is a typical response to this.
Very slow. Okay.
There's VCD.
Good girl. Okay, now you're going to do it with me. Sniffing with me. Sniffing. Good, a sniff. And close the bottle up. Take the bottle outside if you don't mind. I'm sorry. And a sniff again, sniff. Is that kind of what you experience typically? Okay, and sniff again.
So in that case, the patient was responded extremely well. Oh, you know what? Sorry, my computer just did something funky there. This case, the patient responded extremely well, and we're able to control her symptoms within about 15 to 30 seconds. And that's different than the 2 to 3 hours that she normally experienced symptoms. There are other tools that we have as well. IMST is inspiratory muscle strength training. This has been very effective for helping work with our inspiratory muscles. We're working with how fast we can move air with these different respiratory breathing devices. And this is a good example of how we measure it. This is the material that we use when we measure it. And then this is, these are a couple of the trainers that we use for that. So this is the power breather, and this is called the breather. And both of these are very good tools for use with our patients. By using these tools, we're increasing the strength of their ability to move air in, as well as, it turns out, the posterior glottic, the PCA is the muscle that we're also working with, and that's responsible for opening the larynx up wide open. So there's a secondary effect to that. So these are the gains. Again, I'm moving kind of quickly through that, but in conclusion, I want, if you ever have a problem with your breathing, whether it's from VCD or ILO or EILO or whatever acronym you'd like to place on it, we hope that you are able to find a medical team that includes an incredible doctor like Dr. Halum, and I hope you have a trained speech pathologist as well. I think both of them are important to resolving these symptoms. If you do have these symptoms, please know that there is a response to this, that we do have tools in place that can be of help. And that is what I have. So if you have any questions, let me know.
Okay, Rebecca, thank you. And Dr. Halum, fantastic. Really, really interesting. I want to just start off the questions here with something that I saw some allusion to in some of the questions. I'm wondering how often you guys see someone coming in and saying, I was told by someone that I have spasmodic dysphonia. And in fact, you guys then go through a similar analysis and determine that it's not SB.
Very common, very, very common. It's interesting because I feel like over the last maybe 2 decades, and maybe this in part is your organization's impact, we've gone from nobody knowing about spasmodic dysphonia to a lot of people knowing about spasmodic dysphonia, and coming in, for anyone with a little scratchy voice or muscle tension dysphonia or this, type of situation, like my patient who had the chemical exposure, he sounded like he was really tight and strained, and it was just because his cords were in such a reactive, tight state that he couldn't get his old voice back. So yes, it gets mixed up all the time, and it's interesting though how the awareness has improved about spasmodic dysphonia. So now we do see a lot more patients coming in with that kind of presumed diagnosis.
Okay, excellent. Question: how would you approach for ILO in the context of improving symptoms with eating dry foods in comparison to other triggers?
I'll help you out with that one. So one of the things I do is we have a lot of things like graham crackers, or I'll have them bring in the food that triggers them. And we'll work with the idea of breathing and eating at the same time. So sometimes this is a combination of 2 things. You can have a disordered respiratory pattern, and then you can have ILO in there too. So we work with regulating that respiratory pattern, and then we bring it to lunch. So they'll have lunch in my office with me, and we'll work out the breathing issues while they're doing it.
Okay, excellent. Interesting question. Would you please discuss nasal valve collapse in the pediatric population and any correlation to ILO or ELO? Would you also discuss your experience with hypertrophic turbinates and tonsils related to ILO and ELO?
Absolutely. So especially in pediatrics and infants, especially, infants are, obligate nasal breathers. So that pathway through the nasal passage is extremely important for them to have a good airway. So working with the patients to restore a normal airway, whether that be reducing their inferior turbinates or addressing nasal valve collapse, can be a very important part of the therapy. Often, breathing through the nasal cavity is one of the first therapy approaches we use when someone's not exercising. So if they can't breathe through their nose because of an anatomic obstruction, it's a real hindrance to making progress with that kind of therapy. So addressing that is important. But, Rebecca and our speech language pathologists also use other techniques, straw breathing, pursed lip breathing, the tongue approach that she was talking about. I think, there are different ways to get around that, but it's much more challenging in a pediatric group to train them of these different ways. So the nasal airway becomes extremely important.
Okay, super. This has popped up in quite a few questions, and we are hearing it a lot from patient community. And Rebecca touched on you guys seeing people who have had COVID. So could you talk a little bit more about what you are seeing as potentially long-term effects from people having COVID? And then also, are you seeing people who had the vaccines and difficult maybe to make the correlation, but for the individual, they feel like perhaps it was the vaccine that triggered some of their dysphonia problems?
I'm sorry, I was responding to a question about this. Go ahead, Dr. Halum. We do see a lot of them in terms of we see a lot of this in terms of post-COVID, particularly I have with the more of the ILO in terms of just being very trigger happy with almost just about any kind of, a lot of them are cold sensitivity. A lot of it has to do with particular smells that have begun to trigger them, even though in some cases they've lost their sense of smell, but fumes will still trigger. So it's been a very interesting journey with those patients. Yeah, sorry, Dr. Halum, go ahead.
Oh, yeah, you're fine. No, I agree. We see a lot of it after, post-COVID, and it's really just COVID being a virus, honestly. We see a lot of post-viral ELO and, with COVID being a virus and being such a common virus over these last few years here, we are just seeing a lot of post-COVID ELO. But, I think they respond. The good thing is I think they respond just like any of our other post-viral ELO patients. They can do really, really well and get back to normal. The vaccination, that's a very good question. I only have a handful of patients that I've seen who've had problems after the vaccination. So I would say proportionately, it's very, very rare compared to the ones who we see post-COVID. That being said, I had one patient who had a paralyzed vocal fold after the vaccination, and also with the heightened sensitivity and a lot of these ELO symptoms. And then another couple who had more of the ILO after the vaccination. But again, proportionately, that's really rare compared to the numbers that we're seeing who are post-viral, post-COVID. Those, we see every day nearly somebody who's, this post-viral ILO.
Okay, terrific. Thank you. Interesting question. Would you comment on a situation when the false vocal folds engage tightly and dysphonia results? Could you also comment on potential etiology of that condition?
Go ahead.
You want to do this?
I can, sure. So yes, that's a very common one. In fact, it's one of the more common differentials with spasmodic dysphonia, and that's muscle tension dysphonia. So a lot of times the cases are such that patients come in and we call it the Mickey Mouse thing, where the Mickey Mouse syndrome, where they're talking a little bit like this because they're so high and tight and extended. So that is the etiologies for something like that range in various ways. So that can start out as an injury. That can start out with something like a small paresis that, or vocal fatigue, or they've oversung if it's a singer, and I could go on and on, right? There are many different ways it gets started, but it's almost always secondary to a primary issue. So sometimes we see this a lot in our older patients too, who have something called laryngees, which is a bowing of the vocal cords like this. Instead of coming together like so, it's like so. And they end up compensating. So no matter how it manifests, it's almost always a compensation. And so when we can learn a little bit more about the patient, that goes into a really good history taking, then we're able to either work immediately with repositioning the larynx, or it takes a bit longer as we're working with techniques to open up their system and relax it enough for the cords to behave the way they're supposed to.
Mm-hmm. Yeah, I usually tell patients it's almost like limping when you've hurt your leg. Yeah. You know, it's we think of that hyperactive vocal cord where you get that real tight, strained voice. Often there's some underlying issue. They had a virus that irritated their vocal cords, and then they started this kind of limping, and they just, you know, got over the virus. They feel better, but they can't break out of that pattern of speaking. And so that's where therapy can really come in handy, getting back to that normal voice use.
Okay, excellent. Interesting question. Would desensitization training, like those for chronic cough, work for high-low or ELO?
It does. That is one of the big things we do is we desensitize patients to the particular exercise that they are most susceptible to. So I actually responded to someone who asked about swimming. I work with swimmers at the poolside for that very reason, because we really have to get them into a specific, I want to say a specifically targeted therapeutic moment, right? So we want them to experience the problem with support. I actually go to the point of patient failure with support. I know that sounds a little off, but the reason is because I want them to be stressed. I want their system to go through everything it goes through when I'm not there, so that we can work through it and they have something to take with them after that. And we may work a few sessions like that. It could be runners, it could be cyclists. I've worked with wrestlers before. And we often go to the site because sometimes just being in a room, if you've ever been into a wrestler's room, there's a distinct odor that could trigger anybody, even without exercise. but so there's all kinds of things that go into making sure we're as specific as possible as we target this.
Thank you, Rebecca. Question: how did I think it was Stacey, the first patient that you talked about? How did that patient? How did his swallowing do with all of the Botox that you injected into the pharyngeal structures?
Excellent question. Yes, so we do have to be quite cautious with the respiratory dystonia patients because of the swallowing risk. And he did have some swallowing risk when I had injected him bilaterally with that Botox. So I generally have gone to just doing a one-sided Botox. So we'll inject the nasopharynx, the oropharynx, the constrictors all the way down. And then if they do have swallowing problems, they can turn their head toward that side that we've weakened, and they will do much better. So yeah, that's an excellent question, because that is definitely the risk when we're dealing with so many muscles that are involved and trying to do Botox for all those various muscles.
Thank you, Dr. Halum. You commented, I believe, Dr. Halum, you made a comment about patient suffering with stridor. Could you comment on that a little bit more and explain what stridor is?
Oh, sure. So stridor is generally that high-pitched kind of wheezing sound that someone makes when they, usually when they're breathing in. So that's often part of the history too. We'll say, are you making noise when you're breathing in, and that type of noise, or is it more of a wheeze, your asthma kind of wheeze when you're breathing out? Because that really helps us try to figure out where it's coming from. And so the vocal cords tend to be the culprit when it comes to that stridor, whereas asthma is often more of the issue if it's more an exhalatory wheeze. And then every once in a while we get some of these more unusual cases, like with respiratory dystonia. They often will have almost a stertor, so their upper airway, all those muscles, those constrictors, are what tends to make a lot of noise. So you'll hear that kind of almost stertorous noise. So yeah, trying to figure out the noise involved can help us as we're evaluating the problem.
I've noticed a few questions from people asking, have you used cannabis as a treatment option for ILO or ELO in any patients up to this point?
We have not, but I will say I would really like to. I think we actually have had discussions about doing a CBD trial, because I do, incidentally, I found a lot of patients who improve with CBD and various forms of cannabis.
Yeah, I know. I believe Dr. Michael Johns and maybe a couple of other laryngologists around the country are kind of looking at the same thing and talking to a lot of patients as well, Stacey. So it comes up very frequently. And I'm sure you guys hear the question too.
I'd be willing to work on the trial for therapy.
Absolutely.
Good. A question and I've had this question from people over the past few years. The drug gabapentin is used for various generally neurological type conditions, and this particular person is asking about restless leg syndrome. So do you see, or your opinion of any relationship of restless leg syndrome to spasmodic dysphonia, or any type of dysphonia for that matter?
That is a good question. I don't think that I've ever encountered a real direct relationship between the two. I think impaired sleep can affect any of these situations where, of muscle spasticity just indirectly because of stress and impaired sleep. But I can't say that I know of any direct relationship. Do you, Rebecca?
Not a direct one, although if we can sort of telescope out a little bit, it's the idea of hyperreactiveness globally that I have seen in general that they'll have a restless leg syndrome, or they'll have they'll have some other of these more reactive type responses to different stimulus throughout their system, and it will include like a ILO as well. So I say that clinically. I can't say that I've seen any literature on that, but clinically I would say I've seen some of that.
Interesting. Very interesting. Could you guys take a couple of minutes and comment again on how you differentiated between respiratory dystonia and ILO?
Generally, it can be really difficult to differentiate between the two, but it's the lack of response to our therapy techniques that is probably, you know, the most conclusive way that we figure it out. So, we've got about 4 patients now that we regularly manage with respiratory dystonia, and all 4 of them have gone through therapy first, and they do not improve whatsoever with therapy. It's, if anything, it seems to almost make it worse, because the more they focus on trying to get a big breath, even doing all these different techniques, it just gets tighter and tighter and tighter. So really, that's one that we use therapy as both, as really a diagnostic for us, and trying to figure out what the underlying disease is. And it does have a little bit of a characteristic look to it, with all the muscle groups being involved, rather than being more laryngeal focused.
Interesting. I think we'll end with one more question here. How often are you performing supraglottoplasty for these patients?
Good question. Very rare. I can count on one hand. We luckily don't have to do too many supraglottoplasties. But it's an interesting subtype. So worth knowing it's out there. But I did see a lot of people commenting on having spasmodic dysphonia, and that this is not necessarily related to what they have, which I did want to just say, we do treat a lot of spasmodic dysphonia. I really enjoy taking care of patients with spasmodic dysphonia, and although this isn't our topic tonight, we are starting a clinical trial now, using deep brain stimulation for spasmodic dysphonia. So if, put a little pitch out there, if anyone has a special interest in getting involved in a clinical trial, we are actually up and running now. And so we see a tremendous number of patients with spasmodic dysphonia. We manage most of them with Botox and therapy. And but now we do have this new option of also having DBS, so it's exciting.
Great, Dr. Halum, appreciate that. And we have some information on our website, and we'll have more. And again, we're here to support you and help you. And I know that our community is always receptive to participating in various trials, and so we'll have information about your project on our website, so people can contact and participate. So it's exciting. There's a lot of fantastic work going on, and to me, it's amazing how far we've come in such a short period of time. If I look back 6-7 years ago, a lot of the things taking place today in research, we were just dreaming about, even in that short period of time ago. So it's really encouraging.
Agreed.
So I think we'll wrap up for this webinar. Dr. Halum, Rebecca, thank both of you so much. This has been very enlightening, very, very useful for a lot of people, because there are lots of people with many types of voice conditions, and it's good for you guys to talk about some of these other things, because so many times, as Dr. Halum talked about, and Rebecca, you commented as well, there's probably overlap in a lot of these conditions that one of these days we will better understand. And we also know that it's so easy to misdiagnose so many dysphonia conditions. So it's been terrific. I can't thank you guys enough for participating in your terrific presentation. And I want to thank all the participants for joining us for this webinar. And I'm not going to attempt to rattle off all the countries people participating in. I started taking notes, but I'm sure I missed some. So for all of you, participating wherever you are around the world. Thank you so much. Please go to our website, dysphonia.org. We have lots of good information there that I'm sure can help you and hopefully lead you in a direction to get more assistance that you're looking for whatever your voice condition is. So our next webinar will be March 29, and Dr. Joel Blumen will be our guest speaker for that webinar. And it will be another interesting webinar. Dr. Blumen is going to talk about what it's like for a day in the life of a laryngologist. So we're trying to kind of mix it up a little bit and get different inputs and different discussions going. So hope you guys can join us March 29th for the next webinar. So again, Dr. Halum, Rebecca, thank both of you so much. We appreciate it. And all the participants, thank you. And all the best to all of you. So long.
Very good.
Thank you.
Thank you.